This recording will go over acute pancreatitis. Acute pancreatitis is a serious and at times life-threatening inflammation of the pancreas. This process, which affects the body's immunity, is caused by a premature activation of excessive pancreatic enzymes that destroy ductal tissue and pancreatic cells, resulting in autodigestion and fibrosis of the pancreas. So basically, these enzymes that the pancreas is normally secreting actually do damage to itself. That's the term autodigestion that is talking about. The pathologic changes occur in different degrees. The severity of pancreatitis depends on the extent of inflammation and tissue damage. Pancreatitis can range from mild involvement, evidenced by edema and inflammation, to necrotizing hemorrhagic pancreatitis. The pancreas is unusual in that it functions as both an exocrine gland and an endocrine gland. The primary endocrine disorder is diabetes mellitus. The exocrine function of the pancreas is responsible for secreting enzymes that assist in the breakdown of starches, proteins, and fats. These enzymes are normally secreted in the inactive form and become activated once they enter the small intestine. Early activation within the pancreas rather than the intestinal lumen results in the inflammatory process of pancreatitis. Direct toxic injury to the pancreatic cells and the production and release of pancreatic enzymes results from the obstructive damage. After pancreatic duct obstruction, increased pressure may contribute to ductal rupture, allowing spillage of trypsin and other enzymes into the pancreatic parenchymal tissue. Autodigestion of the pancreas occurs as a result. In acute pancreatitis, 4 major pathophysiologic processes occur: lipolysis, proteolysis, necrosis of blood vessels, and inflammation, all of which impact the body's immunity. The hallmark of pancreatic necrosis is enzymatic fat necrosis of the endocrine and exocrine cells of the pancreas caused by the enzyme lipase. Fatty acids are released during this lipolytic process and combine with ionized calcium to form a soap-like product. The initial rapid lowering of serum calcium levels is not readily compensated for by the parathyroid gland. Because the body needs ionized calcium and cannot use bound calcium, hypocalcemia occurs. Proteolysis involves the splitting of proteins by hydrolysis of the peptide bonds, resulting in the formation of smaller polypeptides. Proteolytic activity may lead to thrombosis and gangrene of the pancreas. Elastase is activated by trypsin to cause elastic fibers of the blood vessels and ducts to dissolve. The necrosis of blood vessels results in bleeding, ranging from minor bleeding to massive hemorrhage of pancreatic tissue. Another pancreatic enzyme, kallikrein, causes the release of vasoactive peptides, bradykinin, and plasmakinins known as kallidin. These substances contribute to vasodilation and increase vascular permeability, further compounding the hemorrhagic process. This massive destruction of blood vessels by necrosis may lead to generalized hemorrhage with blood escaping into the retroperitoneal tissue. The ultimate impact to a patient's immunity occurs in the presence of hemorrhagic pancreatitis. The patient with this disorder is critically ill, and extensive pancreatic destruction and shock may lead to death. The majority of deaths in patients with acute pancreatitis result from irreversible shock. The inflammatory stage occurs when leukocytes cluster around the hemorrhagic and necrotic areas of the pancreas. A secondary bacterial process may lead to a suppuration or pus formation of the pancreatic parenchyma or the formation of an abscess. When infected lesions are severe, calcification and fibrosis occur. If the infected fluid becomes walled off by fibrous tissue, a pancreatic pseudocyst is formed. Acute pancreatitis may result in severe life-threatening complications that affect the body's ability to protect itself via its immunity. Jaundice occurs from swelling of the head of the pancreas, which slows bile flow through the common bile duct. The bile duct may also be compressed by calculi or a pancreatic pseudocyst. The resulting total bile flow obstruction causes severe jaundice. Intermittent hyperglycemia occurs from the release of glucagon, as well as the decreased release of insulin due to damage to the pancreatic islet cells, or islet cells. Total destruction of the pancreas may occur, leading to type 1 diabetes mellitus. Left lung pleural effusions frequently develop in many patients with acute pancreatitis. Atelectasis and pneumonia may also occur, especially in older adults. Multi-system organ failure is caused by necrotizing hemorrhagic pancreatitis. The patient is at risk for ARDS. Coagulation defects are another major potential complication and may result in death. Shock in acute pancreatitis results from peripheral vasodilation from the released vasoactive substances and the retroperitoneal loss of protein-rich fluid from proteolytic digestion. Hypovolemia may result in decreased renal perfusion and acute renal failure. Paralytic ileus results from the peritoneal irritation and seepage of pancreatic enzymes into the abdominal cavity. In many cases, the cause of pancreatitis is not known, but many factors can injure the pancreas. The most common cause is biliary tract disease, with gallstones accounting for almost half of the cases of obstructive pancreatitis. Acute pancreatitis may occur as a result of trauma from surgical manipulation after bile tract, pancreatic, gastric, or duodenal procedures. Pancreatic attacks are especially common during holidays and vacations when alcohol consumption may be high, especially in men. Women are affected most often after cholelithiasis and biliary tract problems. They are also most at risk for pancreatitis within several months after childbirth. Most often, the patient reports severe and constant abdominal pain with acute pancreatitis. Conduct the interview after pain is controlled. Ask about whether the abdominal pain occurs when drinking alcohol or eating a high-fat meal. Obtain information about alcohol usage, including the amount consumed and how often. Question the patient about a family or personal history of alcoholism, pancreatitis, trauma, or biliary tract disease. Ask about whether any abdominal surgical interventions have been performed recently. Ask about other problems known to have caused pancreatitis, including peptic ulcer disease, renal failure, vascular disorders, hyperparathyroidism, and hyperlipidemia. Inquire about viral infections and ask about which prescription and over-the-counter medications the patient is taking. In regards to signs and symptoms, typically a patient is diagnosed after presenting with severe abdominal pain in the mid-epigastric area or left upper quadrant. Assess the intensity and quality of pain. The patient often states that the pain had a sudden onset and radiates to the back, left flank, or left shoulder. The pain is described as intense, boring, and continuous, and is worsened by lying in the supine position. Often the patient finds relief by assuming a fetal position, or by sitting upright and bending forward. He or she may report weight loss resulting from nausea and vomiting. Obtain the patient's weight. When performing an abdominal assessment, inspect for generalized jaundice. Gray-blue discoloration of the abdomen or periumbilical area. Gray-blue discoloration of the flanks caused by pancreatic enzyme leakage to cutaneous tissue from the peritoneal cavity. Listen for bowel sounds. Absent or decreased bowel sounds usually indicate paralytic ileus. On light palpation, note abdominal tenderness, rigidity, and guarding as a result of peritonitis. Respiratory problems such as left lung pleural effusions, atelectasis, and pneumonia are common in patients with acute peritonitis. Auscultate the lung fields for adventitious sounds and diminished breath sounds and observe for dyspnea or orthopnea. For the patient with acute pancreatitis, monitor for significant changes in vital signs that may indicate life-threatening complication of shock. Hypotension and tachycardia may result from pancreatic hemorrhage, excessive fluid volume shifting, or the toxic effects of abdominal sepsis from enzyme damage. Observe for changes in behavior and level of consciousness that may be related to alcohol withdrawal, hypoxia, or impending sepsis with shock. If excessive alcohol is a causative factor, tactfully explore the patient's alcohol intake history. Diagnostic lab abnormalities are typically in patients with acute pancreatitis. A variety of pancreatic and non-pancreatic disorders can cause increased serum amylase levels. In patients with pancreatitis, amylase levels usually increase within 12 to 24 hours and remain elevated for 2 to 3 days. Persistent elevations may be an indication of duct obstruction or pancreatic duct leak. Remember, normal amylase is 30 to 220. Lipase also helps to determine the presence of acute pancreatitis. Serum levels may rise later than amylase and remain elevated for up to 2 weeks. Normal lipase is 0 to 160. The cardinal diagnostic tests for acute pancreatitis include the increased serum amylase, lipase, trypsin, and elastase. Other diagnostic tests may include elevated serum glucose, elevated bilirubin, ALT and AST, as well as elevated leukocyte count and decreased serum calcium and magnesium. Abdominal ultrasound is the most sensitive test to diagnose causes of pancreatitis, such as gallstones, and can be performed at the bedside. However, it is not helpful in viewing the pancreas because of overlying bowel gas. Therefore, contrast-enhanced CT provides a more reliable image in diagnosis of acute pancreatitis. Abdominal X-ray may also reveal gallstones. Chest X-ray may show elevation of the left side of the diaphragm or pleural effusion. Pancreatic stones are best diagnosed through ERCP.